Did you know smoking is good for the environment because it kills the human beings, which are the most common reason of causing the damage to the environment. So the human beings should be avoided on the earth to contaminate the environment. Now, in malaria, genetic resistance, several genetic factors provide some resistance to malaria, like sickle cell trait, thalassemia traits, glucose 6 phosphate dehydrogenase deficiency, absence of the Duffy antigens on the red blood cells. Sickle cell trait causes a change in the hemoglobin molecule in the blood. Normally, red blood cells are very flexible, biconcave shape, so they can move easily through the narrow capillaries. But modified hemoglobin S molecule crowd together due to the dehydration, and they form strands, so the cell distort into a curved sickle shaped hemoglobin, and cell is not now flexible enough to circulate freely in the circulation. Sickle infected red cells are removed from the circulation, and so they reduce the frequency of the malaria, so that is protective in nature. Individuals who are homozygous have sickle cell anemia, and those who are heterozygous are resistant to the malaria without severe anemia. Now, the classification of the malaria. Malaria is classified into either severe or uncomplicated, or one can say non-severe or simple by the WHO. If following criteria are present in any patient, it is severe, otherwise it is uncomplicated. So the patient with decreased consciousness, significant weakness, person is unable to walk, inability to feed, two or more convulsions has happened to the patient, low blood pressure, breathing problems, and the circulatory shock. These are all the parameters of severe malaria. Now, kidney failure or hemoglobin in urine, bleeding problem or hemoglobin is less than 5 gram per deciliter, pulmonary edema, blood glucose is less than 40 milligram per deciliter, and acidosis or lactate level of greater than 5 millimole per liter, a parasite level in the blood of patient greater than 100,000 per microliter in low intensity transmission area, and it is 250,000 per microliter in high intensity transmission areas. Now, the types of the malaria, number one is algid malaria, that is by Plasmodium falciparum, severe malaria affecting cardiovascular system and causing chills and circulatory shock. Bilious malaria, it is by Plasmodium falciparum, severe malaria affecting the liver, so the name is bilious malaria. It causes vomiting and the jaundice because it affects the liver mostly. Then third is cerebral malaria, that is by Plasmodium falciparum, severe malaria affecting the cerebrum of the brain. Then fourth is congenital malaria, that is by the various plasmodium introduced from the mother via the fetal circulation. So that is vertical transmission. Then number 5 is pernicious malaria. It is by Plasmodium falciparum, severe malaria leading to the grave illness. Number 6 is malignant malaria, that is by Plasmodium falciparum, severe malaria leading to the death of the patient. Then transfusion malaria, as the name is indicative, that is by the various Plasmodium is introduced by the blood transfusion, needle sharing or needle stick injury to the other person. Number 8 is quartan malaria, that is by Plasmodium malariae paroxysm every fourth day. For that reason, it is called quartan, that fever occurs after every fourth day, counting the day of the occurrence as first day. Then quotidian malaria, that is by Plasmodium falciparum, Plasmodium vivax, Plasmodium knowlesi, paroxysm occur daily, so that's why it is called quotidian. Then 10th is tertian malaria. It is by the Plasmodium falciparum, Plasmodium ovale, Plasmodium vivax. Paroxysm occur every third day, so the name is tertian malaria, counting the day of occurrence as first day. Now, what is the diagnosis of the malaria? There are 7 parameters for that. Number 1 is symptoms plus the travel history. Number 2, blood examination. Number 3, rapid diagnostic test. Number 4, serological test. Number 5, therapeutic test. Number 6, bone marrow or the liver biopsy. And number 7 is culture and PCR. The first is the symptoms plus the travel history. Due to the non-specific nature of the malaria symptoms, note the symptoms of the patient and also note down the travel history of the patient to reach the diagnosis. WHO recommends clinician should suspect malaria in any person who reports having fevers, temperature above 37.5 without any other obvious reason and cause. Suspect in children with signs of the anemia. Hemoglobin is usually below 8 gram percent and patient the kid have the pale palms. Now, trace possible exposure to the malaria, travel to a malaria endemic area and unexplained fever to reach to the diagnosis. Number 2, blood examination. Malaria is confirmed by the microscopic examination of the blood film to detect presence of the parasite in the blood. In the microscopy, we do examine the Gimza stained blood film under the light microscope, and that is the gold standard for the diagnosis of malaria. And examine both thick film of the blood to scan many blood cells in a short time to see the parasite density, and also make a thin film to clearly see the individual parasites and identify the infecting Plasmodium species. Take the sample during pyrexia because the parasites are maximum, and before any medication, then one can see the parasites in the blood film. Single dose of the anti-malarial drug make disappear of the parasite from the blood, so you will have the negative result. Also, there is anemia, hemolytic type, leukopenia or leukocytosis may be seen. There is monocytosis and no eosinophilia is seen. As one can see here, that is the thick film to see the density of the parasite, and that is the thin film to see the species of the parasite And here one can see these kind of things under the microscope. So that is the schizont of Plasmodium falciparum, and one can see the gametocytes in the blood like this. Similarly, in Plasmodium vivax, one can see the trophocyte like this, the parasite in the RBCs, and the schizont when it changes to the schizont, and one can see the gametocyte like this. Similarly, in Plasmodium ovale, the RBC starts like this, and the multiplication leads to form the schizont, which is like this. Similarly, in Plasmodium malariae, the signet cell RBC infected by the parasite that leads to the schizont, RBC schizont, like this, with many parasites inside. Now, there is that Plasmodium falciparum is going to cause malignant tertiary malaria, the 5X is going to cause benign tertiary malaria, and Plasmodium ovale is going to cause ovale tertiary malaria, and Plasmodium malaria is going to cause the quartan malaria. Now, the third is rapid diagnostic tests. These are called RDT. If microscopy is unavailable, use rapid diagnostic test, or it is also called rapid antigen test that detect parasite proteins in a finger stick blood sample. RDTs target the parasite proteins histidine rich protein 2, which is abbreviated as HRP2 in Plasmodium falciparum only, and lactate dehydrogenase or aldolase in the other plasmodiums. Since HRP2 persists in the blood for 5 weeks after an infection is treated, so it is difficult to say and distinguish whether the current malaria is there or it is previously a person had this malaria. And some Plasmodium falciparum parasites, they do lack HRP2 gene, complicating the detection of the malaria. Now, number 4 in the diagnosis is serological test, that is to detect antibodies against Plasmodium or antigen detection in blood, and it have poor sensitivity and specificity. Here one can see the rapid diagnostic test, that is one can see the line that indicates Plasmodium falciparum and no line for Plasmodium vivax, and there is pan for the all if they are present, and that is the control line. And among the serological test, it is negative if the one line is there, and that is for Plasmodium vivax, and the 2 lines are for Plasmodium falciparum. Now, continuing the serological test, antibody detection is done by indirect fluorescent antibody test or complement fixation test, or the other way is enzyme immunoassay, flocculation test, heme agglutination test, and the antigen detection is done by immunochromatographic method. Number 5 in the diagnosis is therapeutic test. In the past, it was said that the chloroquine is given to a suspected patient of malaria, and we do see there is decrease in temperature and the patient recover, so that is a therapeutic test by the chloroquine. Number 6 in diagnosis is bone marrow or the liver biopsy, that is we do aspirate and do the biopsy, aspiration biopsy, to find the parasite in the bone marrow or in the liver. Then number 7 in the diagnosis is culture and PCR. On RBCs, serum and other organic compound, the test is done and it is highly sensitive, poor specificity for the active infection. Now, the differential diagnosis of the malaria Number one is the typhoid because malaria is seen in typhoid patient on the treatment, hence dual infection can exist. There is false positive Vidal in malaria, but there is negative blood culture for the malaria parasite. It is non-changing titer, lower than diagnostic titer, and fever is responding to the anti-malarial drugs. So that is how one can just see that it is typhoid or malaria, but it mimics the typhoid. Other one have to rule out from the other diseases. These are septicemia, leptospirosis, encephalitis B, cholangitis, dengue, influenza, Ebola, shigellosis, Lassa fever, yellow fever, viral hepatitis, typhus, and rheumatic fever. Here one can see the love of the lady. The lover have died and she is just lying on the grave of the man to whom she once used to love, and now after the death she is just sleeping on the grave of her lover. Now, coming to the treatment of malaria, anti-malarial medications, depending upon the type and the severity of the disease, in the endemic areas, confirm malaria before the treatment is given. That is, one can avoid increasing drug resistance. Use the combination of anti-malarial medication. In simple malaria, use the oral medication artemisinin plus either mefloquine, lumefantrine, or sulfadoxine, pyrimethamine, or artemisinin plus other antimalarial known as artemisinin combination therapy or ACT or ACT is about 90% effective for Plasmodium falciparum infection. Artemether lumefantrine 6-dose regime is better than artemether lumefantrine 4-dose regimen. Other regimen to treat falciparum malaria is dihydroartemisinin plus pipraquine. Quinine plus doxycycline, if the artemisinin is not available, can be used for the difficult cases. Now, here one can see that is artemisinin 200 milligram, 120 milligram, and 20 milligram. Then there is the combination of mefloquine hydrochloride plus artesunate, and then there is sulfadoxine and pyrimethamine. There is combination of pipraquine tetraphosphate plus dihydroartemisinin, and there is artemether and lumefantrine tablet, and there it is the gold standard quinine is available. Other effective regimens are artemisinin, naphthocquine combination, then atovaquone, proguanil. Addition of the artesunate reduce the failure and resistant cases. Amidoaquine plus sulfadoxine pyrimethamine is also used. Chlorproguanil dapsone role is not yet clear. Primaquine plus artemisinin combination is effective. Sulfadoxine pyrimethamine plus artesunate is also effective. In Plasmodium vivax, Plasmodium ovale, or Plasmodium malariae infection, use chloroquine or with artemisinin based combination therapy. To clear the parasite from the liver, use primaquine or tafenoquine, that is for the hypnocytes which have been hidden in the liver. In pregnancy, quinine plus clindamycin in first trimester and ACT in the second and third trimester, that is artemisinin containing treatment. And here one can use doxycycline capsule 100 milligram, then artemisinin and naphthoquine, and then atovaquone and proguanil tablets, and amodiaquine plus sulfadoxine pyrimethamine, then chlorproguanil and primaquine, which are used for the different one. Now, continuing the treatment, severe and the complicated malaria by the Plasmodium falciparum has 10 to 50% mortality rates, so one have to use intravenous antimalarial drugs. Parenteral artesunate is superior to the quinine. Previously, quinine was being used. Now, artemisinin derivatives, artemether and artether are as good as quinine. So, use sportive measures in the critical care unit also. Quinine loading dose shortens duration of the fever and increases the parasite clearance from the body. Intrarectal quinine is equal in efficacy to intravenous or intramuscular quinine, that is best used in case of the children, those who are not willing to have intramuscular or intravenous treatment. Rectal artesunate reduce the rate of the death for children with severe malaria. Now here one can see the Dapsone 25 milligram, clindamycin 300 milligram, chloroquine tablet, and the very famous fancy dart tablet that contain sulfadoxine and pyrimethamine, and that is tafenoquine tablets, which are being used for the difficult cases. Now, continuing the treatment, cerebral malaria, severe and the complicated malaria with the worst neurological symptoms is there. Here the patient is in coma, so rule out the other causes like bacterial, viral or fungal infection. Monitor the vital signs, blood transfusion in children to improve the anemia, and role of the osmotic agents such as mannitol or the urea and the steroids is debatable, means not very clear. Phenobarbital is slow intravenous injection of the benzodiazepine cause fewer convulsions, and monoclonal antibodies like L9, LS protect the malaria. It binds to the Plasmodium falciparum circumsporozoite protein, that is CSP1, which causes the disease, so make it ineffective. Now, there is the classification of antimalarial drugs. The first is cinchona alkaloid, contains the quinine, 4-aminoquinolone that contains chloroquine, amodiaquine, and pipraquine. Then diaminopyrimidines, that is pyrimethamine. Then 8-aminoquinoline, that is primaquine and bullaquine. Then sulfonamides and sulfone, that is sulfadoxine, sulfamethoxyrazine, and dapsone. Then sesquiterpene lactones, that is artesunate, artemether, and artether. Then quinoline, methanol, that is mefloquine. Then tetracycline, that is doxycycline, amino alcohols, halofentrine and lumefantrine. Then manic base, that is pyronaridine. Then naphthoquinone, that is atorvaquone, and biguanide, that is proguanil and chlorproguanil. Now, the resistance to the malaria. Resistance has developed to the chloroquine in Plasmodium falciparum malaria. Even partial resistance to the artemisinin has been seen. The cost of the artemisinin limits their use in the developing birds And another reason is artemisinin monotherapies in subtherapeutic doses and substandard artemisinin is also responsible for causing the resistance. And resistance to the combination of artemisinin and piperacillin also has been seen. So, if you want to give way to anything comfortably, you can just give the way. But if you don't want to give the way, you can demolish it and make the road clear. So that is just the accommodation of the road and the place which is already there. So the beautiful scene of a road passing through the mouth of this giant person's face. Now, coming to the prevention of the malaria, there are 8 parameters for the prevention of the malaria. Number 1, prevention of bites. Number 2, indoor residual spraying. Number 3, insect repellents. Number 4, preventive medication. Number 5, mosquito control measures. Number 6, malaria vaccine. Number 7, modification to the houses. And number 8, other measures to protect yourself from the malaria. Number 1, prevention of the bites by the mosquito nets. Insecticide treated nets, ITNS, are more effective than untreated nets so that the mosquito will not sit on these nets. Mostly used is pyrethroids, piperonal butoxide, PBO, combined with pyrethroid also used. There is risk of mosquito resistant to the insecticide. And here one can see the person inside the net is safe, and here also the family is safe, and that is insecticide treated bed nets which have extra protection than these simple nets. Number 2, indoor residual spraying or IRS. Walls of the houses and the rooms are sprayed with insecticides like DDT as the mosquito rests on the wall. If already coated with insecticide, mosquitoes are killed. World Health Organization recommends also pyrethroid, cyflothrin and deltamethrin. One problem with the IRS is insecticide resistance. Number 3 is insect repellents. Most effective are based on DEET or picaridin chemical applied on the whole body or exposed part of the body so that it repel the insect and the mosquito. Number 4, preventive medication. These are used as prophylaxis before traveling to the malaria endemic area where the plasmodium is resistant. 3 medications, mefloquine, doxycycline, or combination of atovaquone, proguanil are used so that if the person has taken already the medicine, if has been bitten by the mosquito, he will be safe from the malaria. So here the residual spraying on the walls, IRS, and that is the DEET which is being used as a repellent, and that is picaridin, insect repellent chemical applied on the body. Then preventive medication, number 4, prevention is mefloquine is taken once a week. Use drug 1 to 2 weeks before arrival and continue for 4 weeks after leaving so that one can avoid the malaria if one has been bitten by the mosquito during this period. Atovaquone proguanil is started 2 days before and continued for 7 days afterward. These are not practical for endemic area but only to the pregnant woman and short-term visitor. During pregnancy, medication improve weight of the baby at birth and decrease the risk of anemia. Number 5 is mosquito control measures, mosquito elimination by spraying insecticides and draining standing water. It lowers the high human population density, high Anopheles mosquito population density, and high rates of the transmission can be curtailed by this mosquito control program. Here one can see mefloquine hydrochloride tablet, doxycycline capsule, atovaquone, and proguanyl hydrochloride tablet, and that is outdoor mosquito control by spraying at the different places so that we can kill the breeding places of these mosquitoes. Number 6 in prevention is malaria vaccine. For children, it is being used known as RTSS, reduce risk of the malaria by about 40% in children, and another vaccine has 77% efficacy. Mesquerix is the first vaccine approved by the WHO. Then number 7 is modification to the houses, that is to prevent mosquito exposure, that is environment inside and outside the home should curtail density of the mosquito. Window screen should be used. Consider how close home is to mosquito breeding sites, drainage and water supply, availability of the mosquito resting sites, and vegetation around the home, proximity to the livestock and domestic animal should be considered. So here that is Mosquirix word first, malaria vaccine, and there is also the another malaria vaccine, and that is how one can see the house making, the house that is just modification to prevent the malaria by using the screen and other ways. Now, other mosquito control measures are electronic mosquito repellent devices which make very high frequency sounds that keep the female mosquito away, because it is the female mosquito which is responsible for transmitting the disease. Then, fogging effect on the malaria transmission, larviciding by the delivery of the chemical or microbial insecticides or larvivorous fish into the open water containing larva, which is capable of eating the larva of this mosquito. Health education for the awareness of the malaria and anti-malarial mass drug administration to the entire population at the same time is also effective. That is, electronic and ultrasonic mosquito repellers are being used, and that is, it kills both mosquito and housefly larva, that is mosquito fogging. That fogging can get rid of housefly and other things. Then natural sources of larvicidal component are bacteria, lichen, fungi, plants, and algae. These are also capable of killing the mosquitoes. Then use of the fish for the mosquito control. There is certain fish which is very much fond of taking the larva of the mosquito and reducing the mosquito population. Now the last is prognosis of the malaria. When properly treated, a complete recovery is there. Severe malaria can cause death within hours or days, fatality rates of 20% even with the intensive care and treatment. During the childhood, malaria causes anemia during rapid brain development, so the direct brain damage due to the cerebral malaria is seen. Survivors of the cerebral malaria have neurological and cognitive deficits, behavior disorder, and epilepsy. Malaria prophylaxis improve cognitive function and school performance. That was all very comprehensive about the malaria. I have tried to cover every aspect of the malaria as much as possible, and hope so you will like it. If you like it, please subscribe my channel and share it with others, as I have made it quite comprehensive, complete, and